A very good evening, doctors. I am Dr. Kapil Dev Mehta from Wockhardt. And on behalf of Wockhardt, I welcome all of you to this webinar on COVID-19 and mental health. At the outset, I would like to thank the medical fraternity for their devotion and dedication in managing this COVID-19 pandemic. Doctors, as you all aware, or you must have read a lot about the pathogenesis, transmission, treatment, vaccines of COVID-19. But I think one topic which has not been talked about that much is COVID-19 and mental health. Recently, United Nations also issued a warning to nations that because of COVID-19, we can have a next mental health epidemic. So to discuss this topic in length, we have three renowned speakers with us. I would like to introduce them one by one. First, Dr. Samir Parikh. He is currently working as Director of Department of Mental Health and Behavioral Science Department, Fortis National Mental Health Program. He did his MBBS and MD from Civil Hospital Ahmedabad, and he topped in both of them. Dr. Parikh has authored several books. One of the most famous books for children, Let Him Not Sing, First Steps of Mental Health. Then he also runs a sports psychology program for mentoring elite athletes. Dr. Parikh has been advisor to International Mental Health Project with Pacific International Hospital at Papua New Guinea. He's among the most well-known experts of the country on mental health issues. Sir, I welcome you to this webinar. It's an honor to have you.
Thank you. Thank you.
Our next international speaker is Dr. Ankur Puri. Dr. Puri specializes in critical pulmonary medicine, and he is currently working in University of Pittsburgh Medical Center. He is recipient of fellowship from American College of Chest Physicians. He is certified in pulmonary medicine, critical care medicine, and sleep medicine from American Board of Internal Medicine. He has over 23 years of experience in the field of medicine. He did his graduation from MAMC New Delhi, India, and he went his fellowship training from SUNY Upstate Medical Center, New York. Sir, I welcome you to this webinar. Dr. Puri, it's an honor to have you today.
Good morning.
Thank you. And our next international speaker is Dr. Sachin Kedar. He is currently working as Professor of Neurological Sciences and Ophthalmology and Visual Sciences, University of Nebraska Medical Center. He did his MBBS and MD in Ophthalmology from AIMS. Then he did his Neuro-Ophthalmology training from Emory University. He is Division Chief of Neuro-Ophthalmology and Ocular Electrophysiology at UNMC. He is also the Program Director at Neurology Residency. He has the fellowship from American Academy of Neurology, and his academic goals is to develop novel learning tools for research and ophthalmic biomarkers for neurological diseases. Sir, I welcome you to this webinar. It's an honor to have you today.
Thank you so much. Thank you. Good morning, everybody. Or good evening in India, actually.
So, doctors, the flow of program is like that today. First, we will have a talk by Dr. Samir Parikh on COVID-19 and mental health. Then we will have a panel discussion on the mental health of frontline healthcare workers. And then finally, we will take the questions from the audience. Dr. Samir Parikh, over to you for your talk.
Thank you. So I think, I've been taking interactions now with the common public, not so much with the medical fraternity. And in the last 2 months, I've had a lot of engagements, interactions with corporate India, with the NGO sector, school sector, various industries, food delivery industries, retail industries, government agencies. And what I've realized is that whereas it is so important that we continue to give all our focus in working towards the physical management and cure of COVID. And yes, the beds, and yes, the ICUs, and yes, the ventilators and the precautions. But somewhere we need to be able to appreciate the fact that there is an underlying epidemic of mental health, which is almost coming out and might well erupt like a volcano if we don't actually do something about it. WHO has recognized that. The recent stories, Bloomberg talked about that. There is a concern around a rise of depression. There is a rise around, my thought is a bit around social side component as well. There is a concern around what if we have a rise of self-harming behavior with the impending finances and the economic impact that is happening. And this impacts everybody. Although we will be talking about the medical fraternity, but I think it's important for us to understand, even as doctors, we are still as much a part of the social milieu and everything affects us in the same way. I'll give you my own example. So we have Arogya Setu here. So 3 days back, I was coming to hospital at our FMRI Gurgaon. A usual day, I'm still doing all of my consults are online, but because of the web engagements and online consultations, I was finding it much more comfortable to work out of my chamber, which is very safe and all that. So I turned and they were doing the scanning. They said, show me your Arogya Setu. The moment they saw my Arogya Setu, from green out of the blue turned into yellow, which mentioned that I have moderate risk and I've been recently exposed to somebody. So they said, can't let you enter. Had to call up the head of the hospital. They said, first your test needs to happen. Then I went to the flu clinic. I spent about half an hour, 40 minutes in the flu clinic. Let's be very clear, our own hospital. I work there. So, naturally, you will be a priority. Now, still those 35 minutes in the flu clinic, now I speak as a mental health professional, was very, very intriguing. The anxieties in people lying in, the anxieties in the medical staff, the threat potential that was palpable in that area, the worry of consequence ranging from quarantine to impact on the family. And then when I finally went in through that curtain and through the PP, I couldn't recognize my own colleague. And my first thought was, how are you in this the whole day? As a psychiatrist, you don't even wear a white coat for that matter, never worn scrubs. And I realized, and then we waited for those 24 hours for the result to come. And all the thoughts were in my mind. And I thought, if I can think so much, how would anybody else be thinking? I have 4 people at home who are all above 80. And my thought was, if I'm positive, the odds are they would be, what will happen, this, that. And this aspect is something that we need to understand. Doctor or not doctor, a human being is a human being. Anxiety is anxiety. And existential anxiety is the most core-based component of anxiety, as core as it gets to. But I also feel, and something I've maintained, that species that don't experience anxiety and fear don't survive. So you need to experience anxiety to fight it out. And I think it's important for us as medical fraternity. And so that's why my 2 thoughts, and then we start our panel. My 2 thoughts. Thoughts 1 is what we can do as medical practitioners to ensure that we reduce the mental health burden of COVID. And second, as medical experts, what can we do to ensure that we maintain our own well-being as well? So let me start with the first one. Why a mental health epidemic? Because a lot of people are going to be impacted. Finance and economy in modern day is considered to be one of the biggest stressful triggers that is there, because the implications on an EMI generation, on a largely consumeristic society, has always been there. It's only increased. A very warped work-life balance that was there. Most people in any case work near burnout. And from there, the pressure of the targets and the pressure of the pay cards and job cards and the uncertainty, when will things be fine? How will things be fine? Nobody has a clue about it. So all of that is playing on the minds of people, besides the anxiety of having the illness. And it is this component which has brought in the stigma. Again, as a mental health person, I feel that mental health has gone through stigma for generations. For generations, people have stereotyped mental ailments. Generations, people have discriminated. Generations have suffered and not being able to seek help because they just couldn't think they could go for help. And here what has happened is we've allowed stigma to seep in to a physical illness, an infectious physical illness, a virus for that matter. Then whether it is the medical staff going back their home or whether it is neighbors' behavior, so on and so forth, and the kind of stigma that is seeping into our society is also having its own effect on the socio-cultural, socio-psychological churning that is happening. So finance, stigma, anxiety of illness. You put all of that together and the new normal which has a lot more time spent at work, lot more of flexibility of work, lot more of work from home. And I'm amazed at the fact that so many people have come and talked to me in the last few months that, my fights and discomfort has increased because I'm spending more time at home. And, again, from a social psych point, you wonder, this is our family. If spending time with my own family is going to increase differences between us, then we've really messed up in the last 2 decades. Because that's all that matters, isn't it so? Shouldn't spending more time with family should have been our best way? I mean, what better way to quarantine than being with your children, your grandparents, your parents, watching some TV together, playing some games, spending quality time, doing some sports, arts, fun, talking to friends over video connections. What better punishment could it be? And from there, we actually start feeling the confinement and the social isolation. What is social isolation? I wonder. Your family is right there with you. What are we talking about? It's the perception of the social isolation, the perception that I used to meet people. The fact that we've forgotten that bystanders' apathy has been rising. The fact that we forgot that most of us did not know who our neighbors were. The fact that we have not talked to our own friends, our networks, our extended family for what? Years. And today we are actually re-engaging and reconnecting. So physical isolation is largely to do with our perception that because it's a rule, not because in the true sense. So we first recognize this. So when people come to you and seek help, when they come to you for COVID testing, family members come, we will need to take out that 4, 5, 3 minutes extra and talk to them about anxiety, help them understand the perspective in the context of life, let them understand in this 14-day quarantine that people in India are so preoccupied about. And I have been telling them in an 80-year lifespan, bare minimum, what is 14 days? There is no math. You either see it like, 14 days or you see it like 14 days. So you talk about it, you talk to the family and you help them understand that how their own preventive approach can help all of them. Our problem is that none of us in the world are willing to do 100 on 100 when it comes to prevention. We're willing to do 80, but 20 we leave for personal discretion, partly because of carelessness, partly because of sheer callousness, and partly because of narcissism. That we feel, no, somebody else will have, but I'll not have it. So you check that. And then you also screen for sleep disturbance. You screen for anxiety, preoccupying thoughts. You check for mood. You check for whether you are still doing your regular interactions and work. You look at that component also. If that's not happening, give some basic advice. Maintain routine, maintain sleep-awake pattern, hydrate well, eat well, stay connected, do a bit of work, do some physical activity, in the confines, talk to people. This basic advice, a lifestyle-ish advice, will also act as a prevention for a lot of people who would be struggling or be on the borderline of anxiety. This is not the time for the benzodiazepines. This is not the time for the SSRIs. This is the time for reaffirmation, reconfirmation, and supportive guidance that is required by people. Once we do that, it will start becoming a different approach. If you look at the psychosocial component of every family that comes to you, all people who are admitted, it will help you. The second component, before I come to doctors themselves, is the paramedical staff. In my opinion, all healthcare providers worldwide need to start working on the burnout, the emotional burnout component, the mental health component of COVID with paramedical and healthcare staff as well. Because they go through the same anxieties, they're almost discouraged to talk about it because what will people think about it? I mean, we wouldn't be able to hear from a nursing or a paramedical staff who would say that, listen, I'm feeling hesitant, can I take an off today? We would almost feel it, we might fall prey to being very judgmental about it. So we take care of them. We ensure that we talk to them. We create groups. You work on groups because groups of homogeneous people working in similar profile, going through a similar stressful event is very effective. It's time effective, it's efficacy, introducing anxieties in any case there, because it creates a validation. It helps through the identification. It helps through the understanding from each other and the learnings from each other. You know, I had started when the lockdown happened at 11 a.m., 4 p.m. art for mental health, which was on our Instagram page. And we were doing some activity every day. And gradually, after a few days, we realized the sheer number of people, we thought it was for children, and adults outnumbered children gradually because they wanted to do something, learn, enjoy, so on and so forth. So look at that staff. You ensure that you keep giving them the positive stroke, the recognition, not just of the good work they are.
So your voice is not audible.
Yeah, now it is.
Yeah, it's there.
Yeah. So you look at that component that you are also able to keep giving them positive strokes by recognizing that if you are feeling anxious, that's also fine. Because anxiety is as normal as it gets. And then coming to our medical fraternity. We are programmed to take care of others. We are programmed to do those long hours. Not me, I'm a psychiatrist. I'm hardly programmed to do anything for long hours. So I can see both Sachin and Ankur smiling. So yeah, I don't know, how do you guys spend the time that you spend in your OTs and your procedure rooms and the emergencies that you have? Psychiatry saved me for all that. I hardly even consider myself as a medical doctor anymore because I probably might have even forgotten how to look at the basics. But in this flow of things, and I've been asked by a lot of colleagues in media that you tell us that how are doctors coping with it? My answer to that is we will not know that right now. We will know that 3 months down the lane. Because right now, the medical fraternity is in the zone. It's in the group. Nobody is getting the time to think. I mean, I've been talking in our flu clinic with our internists because they're right next door. So they come and have their lunch where my office is there. And so since they're having their lunch, so I have to wear the mask. So, and we sit and I hear them out. And that's the only break that they are taking. So they don't even have the time right now. And even in that break, they have like 50 calls which are coming. And I realized that the amount of work they are doing, the burnout will not happen now. The impact of this is going to happen a few months down the line. And the only way to prevent that is healthcare providers, healthcare associations, doctors themselves will need to find a way to switch it off. They will need to do that. What rotations you create, what channels you create, what delegations you create, but you will need to create some space for yourself because that burnout is a concern. So what do? I have always maintained this, and I know when I say this, most of my colleagues laugh, but you switch off yourself. And I'm hopeful that both Sachin and Ankur will be able to reinforce the fact that you can actually switch off yourself. And if you switch it on, the world doesn't come crumbling down once you switch it on. You might just have way too many messages and calls. And most of those messages are forward, which are quite rubbish in the first place. But the thing is, we've allowed ourselves to believe that we need to be available 24/7. You don't need to be available. No, that's God. The fact is, if you value your mental health, you'll be able to support others better. And you will need to bring that level of comfort at your home as well. So, how do you take care of your family members? By spending time with them. You don't merely take care of your family members by wearing a PPE and hand sanitization. That's robotic. You take care of family members by emotions. And for that, you need to be able to have the space and the time to feel it. I still feel you can touch a bit of music here and there. I still feel you need to read non-medical stuff. I read non-medical far more than medical stuff, more than enough of it in the last 2 decades. So, give me a fiction, give me a travelogue, I'll pick it over a medical journal any day. And not to say that I'm not reading medical journal, because there might be some senior colleagues and my teachers and some here also. So I'm still keeping as updated, if at all there's anything left to be updated. And so bring that, accept the fact that we are humans. Humans need to take care of themselves. Humans are vulnerable. Humans experience anxiety. Humans need joy. Humans need pleasure. Humans experience anger. Humans experience sadness. And humans need to take care of their own families. That's the way you take care of yourself. That's how you keep your mind fit. And on a parting note, before we go to our panel, because you'd much rather listen from the young stalwarts than aging fossils like me, is that we've closeted altruism and empathy worldwide for a very, very long time. Mental health is not about schizophrenia, bipolar, and depression. It certainly is not about the haloperidols and the fluoxetines or the sertralines and the benzodiazepines. Mental health is about the societal component of well-being. And if we all go back to the WHO definition of health, look at it. There is only one tiny component of physical health, and the remaining 4 big components of psychosocial, mental, and spiritual health. And I think that's what we need to value, because like it or not, 1 in 5 people in the world will have a mental health issue. Like it or not, 300 million people in the world suffer from depression. 240 million people suffer from anxiety disorders. Suicide is the 8th highest killer in the world. And it can affect all of us. So if we focus on prevention of mental health outcomes, negative outcomes of COVID, we'll do justice to ourselves, because we'll be able to find the beds and the ICUs and the ventilators, but we won't be able to find the psychosocial support if a pandemic of mental health happens after the COVID is done with. On that note, I will now ask both Sachin, Ankur, and Kapil, can you please help and take it forward?
Yeah, please, sir. Thank you, sir, for setting the tone for the panel discussion. May I now request Dr. Sachin and Dr. Ankur Puri to please join for the panel discussion.
Good evening.
Yeah.
This is Ankur. First of all, Dr. Parikh, thank you so much for especially focusing on the issues pertinent to the healthcare providers. It really hit home, because a lot of the things that you talked about are things that me and my partners, have been talking about, have been experiencing, and we've been experiencing those in our home. Taking care of COVID patients, taking care of, or as things get more liberalized, all of these issues start getting more and more upfront. And on a side note, these days your expertise is more important, if not as important as what anybody else has to offer, because like you said, without the correct mental health perspective, it's hard to handle life these days. And I appreciate your things about switching off that you said. That's the hardest thing to do for most of us people that are healthcare professionals. Sachin, I'll let you go for, I have a question for Dr. Parikh.
Yes, thank you, Dr. Samir. That was really a very nice overview of mental health and how to preserve mental health in these times of stress. Um, Similar to the recent study in India, the Census Bureau in the US has conducted weekly surveys, emergency surveys since I think late April, and they have found that anywhere from one third to one half of all the respondents had some form of mental health problems which were new, like depression or generalized anxiety. And you use the word tsunami. This is probably going to be a super tsunami if one half of your population is struck by these mental health disorders. To the best of my knowledge, I do not know if any studies on healthcare workers specifically have been completed either in India or in the US, but we know anecdotally that the amount of anxiety and the amount of depression we see in our colleagues is high. And recently there was a emergency room provider in New York City who was unable to tolerate the stresses placed because of the COVID-19 pandemic in New York City and ended up taking her own life, which really is a sad state of affairs, because in a world where there is a lack of healthcare professionals, we have to preserve resources. We have to make sure that people who have spent their lifetime are able to take care of the people who need it the most. And as we emerge from this COVID pandemic, I think all of us will be needed in various capacities. And Dr. Samir, I think you will be in very, very high demand if you not already are. So, um, uh, so I will go ahead and have Ankur ask his question, and then I will follow up with mine. Thank you so much.
So, Dr. Samir, one of the things that I wanted to ask you or touch upon is, I think you started talking about that a little bit, but I wanted to see if you could elaborate on, not only healthcare providers, but also as we start opening up economies. It's happening in India, it's happening here, even as cases are going up. And we expect as things open up for cases to go up further. How do you handle the insecurities of healthcare providers as well as patients that are reluctant to go back to work or are worried about going back to work and getting exposed to people as things start opening up? Staying at home indefinitely or doing things by telemedicine indefinitely is not is not a viable option for a lot of people anymore. And and particularly people that have certain predispositions to having a poorer outcome. If they may be older, they might have lung disease, and they may be more exposed than others to people. How do you handle, what's your approach to counseling them as to how to handle that?
So Ankur, you're right. Just before I was on this conference, I just got a call from a younger patient of mine, 24, 25-year-old, started a job recently, and he called up and said that my parents want me to go, and they've got the job after a lot of push, and they think I'm being lazy, but I'm so scared to go because this organization is working at 100% capacity. I'm not sure if the social distancing is enough or not, but they are wearing masks. What do I do? Two, three things. I do feel that worldwide, everybody has felt the pressure of economy. I feel that would have been nicer that we could have maintained our priority of well-being a bit longer. Would have been better for the entire world than waiting, or let's say giving way to the perception of the economy. Because if we go through a en masse morbidity and mortality, frankly, economy is going to struggle in any case. I also feel that mere opening up is not in the true sense opening things up. Opening up is happening a lot more in perception. A predominant part of people continue to be hesitant. I am doing entirely teleconsults. To be honest, I don't think more than even 5% of my patients would have even asked that am I available physically. 95% are so relieved that I'm available through a teleconsult. But then my branch is such where you don't actually need to go through the physical. But I have had so many patients who would have had comorbidity, ideally should have gone to a hospital, but they don't know. They are not able to go. Same applies to workplace. My thought around this is that workplaces which are non-healthcare workplaces will need to bring in a lot more of responsibility. They will need to genuinely filter between the essential, partially essential, non-essential, flexibly essential, non-flexible, and create those kind of segregations. You may increase, you can run around the clock rather than the 8 hour cycle for a few months or a few weeks, but you need to reduce the workforce coming. I think that's something important. I also feel that vulnerable people from vulnerable predispositions, socially or otherwise, will need to be given a lot more empathy. Most people who are joining back with the fear of losing their jobs, and we need to understand that. If nothing else, compassion from employers to understand that one is coming out of the need. Even that recognition, the feeling of support and feeling of recognition can actually be very therapeutic. Same goes for doctors. Although my feeling is that you will still have, let's say, two kinds of healthcare providers. You'll have healthcare providers who will downplay it and then not be very careful, and healthcare providers you will be on the other spectrum, and then most of us being somewhere in the middle, and both of them don't really work. So if you think you can avoid calling a patient and do a teleconsult, I still feel we should do that as far as possible. But if you feel it's an absolute need, then you also give them and yourself the confidence by following the processes fully. I think somewhere, because a process, see, look at the process starts from entering the hospital campus, parking your car, who is driving your car. From there, the first guard you meet, then a couple of lifts you cross, then you have a few screenings. Most of the screenings are essentially about temperature, right? If you have symptoms, you go to one place. If you don't, you go to another. No matter how much you try, there is constant um, dilution happening. It is these kind of things which create a problem. And I think zero tolerance with 100% process approach is the only way. There isn't an easy solution to this.
Right. And the corollary to that becomes, I think you touched upon that again, was there is always going to be not just healthcare providers. The other thing that we are experiencing is there is thankfully only a minority, but there are a certain subset of people who minimize things, whether be it for whatever reasons it might be, because of their own insecurities or their belief systems or whatever, they minimize. But then the other thing that happens is not only do they minimize it for them, but by doing so, they are actually putting other people at risk. So there are people that will not, or patients that will not adhere to social distancing norms. There are patients or people that will not wear a mask. And when they come to your workplace, especially at a physician's office, then it's a very unique situation in which usually a patient's non-compliance puts him at a disadvantage. Here, their non-compliance puts other people at a disadvantage and risk also. And from the way our organization has handled that, we have a protocolized way in which how to address it. But all of those things don't cover every situation, because there's always a small minority of people who get upset. And I'm just, as these things, as patients come into offices more and more, I'm just waiting that there is going to be an issue that's going to come up slowly, where we're going to have a belligerent patient or belligerent family member that wants to be with a patient that's not allowed to be there. And that's going to lead to some awkward situations also.
Yes, I agree.
Sir, your voice is not. Sir, can you?
Yeah, Sachin, you were saying something?
No, I was not. I think we lost you for a few seconds over there.
Correct, sir. I think so. We have again lost him.
So, Sachin, let me ask you something. Are you guys are you doing something protocolized like that to handle a belligerent patient or somebody that refuses to adhere to masking protocols or temperature checks, especially as we see, where some people think that that's an invasion of privacy with somebody else is taking your temperature. I think this issue is less of an issue in India from what I understand, but there's always going to be a minority of people that are going to feel like that.
Yes, that is true, and the University of Nebraska has pretty much assumed a zero tolerance policy for this. You are screened at the door. You are given what we call as conditions of treatment, which means you have to adhere to the no visitor policy unless it's a child or it's a dependent adult with dementia or other diseases like that. You're expected to wear a face covering at all times that you're on. And if somebody is not doing that, we just remind them. If you are refusing it, then we, at least the providers, don't see them. We have not yet had a situation where there has been an open conflict. Maybe that's because of the nature of the state we are in, and the population. But we have
I
not.
think part of it is also right now. My general sense is that there is something different about the perception of this disease in a significant majority of the population being, to some extent at least, scared, or rightfully so, of acquiring it. And maybe that's the reason why we're not seeing that much. But similar protocols are in place at University of Pittsburgh, where there's universal screening. But our area is now moving into the green zone. And as we move into the green zone, I think a lot more people drop their guard, and a lot more people feel that it's less important anymore. And I think that's what I'm afraid of, what's going to happen in overall population base as things get more liberalized, where people don't understand that being liberalized doesn't mean that you have to stop taking care and stop being careful. I think we may have.
Yeah, I'm back.
Dr. Samir is back.
There we go.
Yeah.
So we were discussing how University of Pittsburgh and University of Nebraska are handling the how we're handling the via protocols of a zero tolerance policy about people that refuse to be masked or social distance. Maybe you can touch upon, I don't know if you can touch upon what the thought process behind some of this is in people's mind who will not adhere to these things, even though whether you feel that's because of a lack of understanding or that is something else that drives that.
Yeah, I think the range, Ankur, is from stupidity to narcissism, right?
I think you're correct.
It's the range. I mean, either you're stupid enough that you don't understand what is happening, or you're narcissistic enough that you think it won't happen to you. I just don't know any other way to put this. Very unfortunate. And I think it also speaks volumes about the lack of connect and responsibility we've had with each other, about each other. I think in the decade, we've just lost that connect. Decade and a half worldwide. Our ability to empathize, our ability to be responsible from the context of somebody else's impact on somebody else's life. I think we've just lost that somewhere in our growth, we lost our values.
The individual takes precedence over the society, and maybe this pandemic is trying to teach us that the society is something that us as individuals have to take care of.
That's very interesting what you are saying, because in all my lectures that I've been taking to corporate India, I've been telling them that if you want to win over a pandemic, it's not about individualism. It's about social connectedness, social collectivism, social responsibility. Picking up from something also, because both of you happen to be from the same school that I studied in. When we had moral science classes in school, and you must both, I'm sure, remember it. As children, we thought what a waste of a time. Right now, when you look back at it, you'd rather have your children in one moral and science class every day, right? Because it's those values which were able to filter and give us this strength to still do some good stuff. And we've just taken that away, and we are generating a world that has social media as the educators, social media influencers as the new role models, without any filter, without any values. That's the world we are building. So yes, if COVID can teach us empathy, altruism, basic values, importance of relationships, rekindle, reconnect, maybe mankind deserved it and got something in return.
So
That's
following up on
interesting
that
perspective.
question, Samir, how much of it do you think this kind of a rejection of what would be called as, information-based norms, like refusing to do social distancing, refusing to, kind of what I would call jerk behavior, where you're only thinking about yourself? How much of that is actually a symptom of mental health disorder? Now, you talked of narcissism, you talked of altruism. There are some mature defense mechanisms, there are some immature or basic defense mechanisms. How much of it is a manifestation of that? And how, as providers, can we help such individuals in a positive way without confronting them?
Sachin, I personally feel this negligence that people are having is not, and actually is very less to do with mental health issues. I think it's a lot more to do with social psychological parameters, where I think the communication channels are the issue, right? So for every Ankur or every Sachin who says something, whether in the social media or in a medical journal or in a conference or address a community gathering, there are hundreds and thousands, literally hundreds and thousands per minute messages coming, unfiltered, unverified, reaching people at such a frequency that they are not able to distinguish between sheer fact and fiction here. And that's the confusion. And our problem is that we do not have adequate, consistent messaging, because you and I, as doctors, were never taught marketing. We were never taught messaging. Most of the doctors here who are listening probably are not on Twitter. They are probably, if and when, sometimes on an occasional Facebook. And they would be doing a few WhatsApp messages response to their friends, maybe a few alumni groups like us. And then certainly not on the Instagrams and the Pinterests and the Snapchats of the world. But the real-time conversations are happening there. That's where the influence is coming from. Like, for example, it's coming from newspapers, it's not coming from news channels. It's coming from that smartphone, which is making an idiot out of us. It's that what we need to figure out, and somewhere in years to come, medical fraternity's ability to reach the right message to the community with the right channels in a consistent, pervasive, effective manner is the solution. I'll say do social distancing, suddenly you get 10 more messages. Oh, it doesn't matter, this is rubbish. They are saying this is just like that. This is to buy this is to do that. And suddenly that goes away. And then social conformity takes over. It's
I
very,
think one.
yeah.
I was going to say, I think the medical community is actually adding to it these days too, to some extent, probably not on purpose. With the, like you said, the not data-driven things have somewhat fallen to the wayside uh, throughout the last 3 months of the world dealing with this. You look at the pre-publication papers that were released on uh, treatment, prophylaxis, on a variety of different things coming through, with famotidine being used, hydroxychloroquine being used, macrolides being used, remdesivir being used, this, that, and the other, without any thought to have we proven one thing or the other. And then there is back and forth, flip and flop, and that actually messages the community in general that even professionals don't know what the right thing is. And I think that confuses the picture even more, and that got pulled to the forefront recently within the last couple of days with this huge paper that was supposed to be a game changer about hydroxychloroquine, published in Lancet, and then just yesterday it got retracted. Similarly, a paper in New England Journal, pulling from the same data pool, and unfortunately, there were physicians of Indian origin that were right up front in both of these, and that mixed messages, I think, is throwing the public off even more. It's confusing the heck out of every single clinical provider as to what to do, how to handle this. But I think you're right. It is really confusing the public, and the trust in physicians knowing what they are doing is eroded to some extent because of that.
Yeah.
So, the last few months have been, as Ankur pointed out, really game-changing for most of us. You can say that we have compressed within 2 months our knowledge of a disease that we should have taken a decade or more to know about. So we are pretty much flying by the seat of our pants, literally. So when I look at wellness in general, I wear different hats as a clinician, as a teacher, as a researcher, and as a public health advocate. So wellness for me, the way wellness affects me depends on myself as a physician, my family, and how am I going to take care of them? My parents, my wife, my kids, are they going to be affected? Then comes colleagues and your co-workers. How are they doing? Are we contributing to their wellness, or are they contributing to our wellness? What about my students? We often forget to think that the trainees who are at the forefront are actually hammered worse than some of the senior physicians who are in the background. We also are worried about the wellness of our patients, and sometimes we don't even inquire about how they are doing. Is their wellness okay? Are they anxious? Do we need to treat it or not? And then lastly, as Ankur pointed out, the general population. It's the collectiveness of the people and how they are feeling that impacts the individual. So we are all a part of our society. If our society is not doing well, then we get impacted by it. We cannot be isolated from it. So my question to you as an expert is, are there differences or similarities in these situations where we talk about these different groups of individuals as it affects the healthcare provider? Because the healthcare provider comes from the community. And so do we look at these differently, or can we manage wellness in this age, in this time, similar in a sort of a general way?
I think the healthcare provider comes from the community, Sachin. And I also feel that the healthcare providers themselves have struggled to give mental health the kind of priority that they should have given it a long, long time back. I think a lot of stigma and judgmentalism that mental health has gone through has also gone through because somewhere the collective healthcare providers across the world have never been able to prioritize mental health. Whether it is because of the economy of mental health, whether it is because of the dearth of the expert, whether it is because of the fact that it's an infantile science at best, which was virtually non-existent before 50s. I mean, chlorpromazine came in 50s. So you're still looking at the first tablet, which was a terrible tablet that came 70 odd years back. And by the time you had other meds coming in, and 90s was the era of designer medications and psychiatry. So that's 30 odd years back. So all of this has played a role, and it continues to play a role. I mean, even today, you might end up having gone to a physician of any specialty who might tell you that, no, let's wait, let's not be in a hurry, it's okay. We almost downplay it. And in a country like ours, our problem is we have an 800% shortage of experts. I've been taking it at multiple levels and platforms. There is no way in the next 2 decades we'll be able to have enough mental health experts in our country, no matter what we do.
Yeah.
Our best case scenario is preventive and community. Our best case scenario is taking healthcare almost the Anganwadi route and taking care to the primary healthcare level. Our strength is Digital India. If Digital India is used with public-private partnership, because 85% of mental health is in the private sector. If you use that, create the digital reach the maximum level, but focus on preventive. If we don't focus on preventive, which is stigma, help-seeking behavior, support, basic skills like assertiveness, problem solving, coping with stress, basic importance of lifestyle, relationships, and communication. If we don't do this and help build resilience, and resilience is psychological immunity in a way. So if you don't do that, then we'll have more and more morbidity, and we just don't have the bandwidth to deal with it. That's a fact. COVID has taught us that. We never thought collectively as healthcare worldwide we would ever have a situation where beds could be an issue. I mean, most private healthcare providers have been struggling with their occupancy, and today they don't have beds. That was an unimaginable situation. So imagine what's going to happen when the mental health epidemic would just blow into our faces. And I think doctors are a part of the community builds doctors, it's a whole vicious cycle. So at community root level, the change needs to happen. And my take on that is that only young people can be worked upon. Adults are unchangeable. Adults are adulterated by their own experiences. Adults are very difficult to, I don't like to bang my head on the wall. So I talk to children, that's why I try and see if we can bring some hope for the future, because present has been eaten up by us.
Sir, can we have the questions from the audience? Some questions?
Yes, please.
So please, can we have the questions from the audience? Yeah.
Please.
Okay.
Yeah, yes, please.
So one of the recent studies published in Asian Journal of Psychiatry demonstrated that around 80% of the people are preoccupied with COVID-19 disease. First of all, is this normal? This preoccupation with COVID disease, that I will contract the disease?
I think Ankur just answered that question about how in a hurry we are to keep giving data. How do we measure preoccupation? Right, we'll have to find a scale to decide on preoccupation, which is still not going towards anxiety, but preoccupation. But let's understand this. Why do you need a journal to tell you a basic fact? If there is fire in your house and if there are 10 people, you expect 8 or 9 of them to be anxious about it, right?
Correct,
You don't
sir.
need to do a Hamilton anxiety scale to know the rates. So if there is a pandemic which is affecting almost every other person and has the potential of affecting every other person, of course you'll be preoccupied, you'll be anxious. That's as normal as it gets. You'd rather be anxious, because if you're anxious, you'll probably take some care and preventive measures.
Okay. And so when to seek help for this preoccupation? When this becomes a disease?
Preoccupation is not a disease. You seek help when you can't deal with it with the help of your family and support systems. That's when you seek help. You seek help when you have impairment of functionality of your life. You don't seek help when you feel low. You listen to a ghazal and you think of old times and you feel low. That's not depression, right? That's not depression. You have a breakup and you don't feel like sleeping for 2 days. That's not insomnia. Impairment of functioning in a consistent manner is when you seek help.
Correct. So Dr. Ankur also pointed out that recently a study was published in Lancet, one of the biggest studies on HCQ, and then it was retracted. So I just wanted to know from you, is digital distancing necessary currently to maintain the mental health? Because we get a lot of stuff on the WhatsApp, on social media.
We just have to be media literate. I have been doing media literacy for the past 10 years with young people. Be media literate. You will get WhatsApp, but surely you are intelligent enough to distinguish between rubbish and what is not rubbish. If Ankur or Sachin send you a message about some medical fact, there is evidence. But if somebody from a non-medical background is sharing some rubbish with you, you delete it, not forward it. It's this stupid forwarding which allows some of these social media houses to actually thrive. It's the filters that make you take more selfies, because none of us is pretty enough in any case. That you will put a feed with your own number, 100, 200 pictures. It's embarrassing, the least to say. You go out today and you see young people watching sunset, they're clicking their own pictures. The sun is far more pretty. It's a social conformity and lack of media literacy. Delete. And frankly, if somebody sends you a stupid message, you should block that person also.
Correct, sir. So, maybe if you take in today's scenario, a person suffering from COVID or diagnosed with COVID, or his family, it's almost like a death sentence in India, I believe. No, it's not.
It's not fair.
No.
Let Ankur or Sachin answer the facts. Statistically, that's incorrect. Either one of you guys, I'm not a doctor. Can you please correct this one?
Yeah, there is definitely, there is no data supporting that. You just look at the death rates, even in India. In India, they're lower than what has been reported at other places. But even if you take the highest death rates, just having COVID doesn't mean, the chance of death from that is so low that you don't want to be thinking about that. You're less than 5% definitely in even, most of the series, and even 2.5%, which is similar to the major complication rate of some elective surgeries, and so I think, again, like what Dr. Parikh had touched upon before, a lot of it is about perception, and it is about fear mongering in a way. And I think trying to focus on hard facts is harder these days, but it is even more important, because otherwise we end up feeding into exactly this kind of fear mongering and making it worse, particularly if healthcare providers feed into it. So that, I think, gives us a unique responsibility of being very, very careful as healthcare providers not to pander to some of these fear things. And like Dr. Parikh had touched upon, yes, you can, for a non-medical provider or a non-medical person, forwarding something on social media is something that one can, in a reasonable way, say, okay, we are not going to believe that. It makes it even more important for a healthcare provider to be extremely careful, responsible about their social media presence, because whether we like it or not, there is a huge presence of social media and huge impact of social media, particularly when people are stuck at home. And I think it behooves us to be extremely important as healthcare providers to be very careful about our social media presence.
Correct.
Yeah,
So
I agree.
Dr.
One of the things that we've seen in the COVID pandemic is the social media groups, as Dr. Parikh was pointing out. And with all the physicians on this forum today, some of the data that we now have from a population base comes from Germany and other European countries. it looks like if you account for asymptomatic patients also, if you have 1,000 people, then probably about 900 of them are going to be asymptomatic or mildly symptomatic. Probably 100 of them are going to have, more moderate or severe illnesses. Anywhere from 1 to 5 of those 1,000 will die, which means your case fatality rate of all those infected, including asymptomatic, is probably less than 1%, I think. So, and these low numbers are probably true for India. If the numbers are accurate from India, that is probably true, and I'm really thankful for that.
So India is, yeah, please
go ahead.
So India is currently reporting mortality of 3%, roughly around. That's what's reported in news centers.
But
what you're
we're
talking
not
about
testing
is
everybody.
Exactly. So
Sir,
you have a
our
lot of
testing is around,
asymptomatic.
yeah. Sir, our testing is around 2,200 per million. I think US is testing around 40,000 per million, if I'm
No. What I think Sachin's point is that there, with India's population, even if the testing ramps up, you will not get an accurate count of everyone that has acquired it, because there is a significant percentage that is going to be completely asymptomatic. And those people are at the bottom of the ladder as far as testing priority goes. Because if there are only certain number of tests that can be done, they are understandably done on people that have symptoms, because you can't possibly test everybody that's asymptomatic currently because of the testing capability that one has. And with that, so the case fatality ratio or the rate that you're talking about is only within the people that are tested. And a majority of the people that are infected are likely not part of the denominator.
So this is important for everybody to understand. We are not testing everybody. So in a population, when I talk about a population, if you see 1,000 people who got this infection, if every 1,000 of them get the infection, 900 of them are probably going to be asymptomatic or mildly symptomatic. 100 are going to be moderate to severely ill, and perhaps anywhere from 1 to 5 of those 1,000 may die. And so when you talk about the case fatality with a positive, that's a different thing. And Ankur can correct me if this is not, if this is erroneous. It is believed that for everybody that you tested positive, there are probably anywhere from 5 to 10 times as much in the community, the spread. So if you extrapolate that data, your case fatality is probably 1% or less. So when Ankur said 2 to 4%, that's what he meant.
Even lower, yes. So there's one question from for you, Dr. It's about George Floyd, about the violence that happened related to the death of George Floyd. So do you feel that this can lead to aggravation of underlying anxiety in people because of unpredictable future?
This is a question for whom?
Or Dr. Ankur?
Dr. Ankur, okay.
Oh. Well, I think anything, whenever that's a very, very loaded question in today's day and age. However, I think that's a very simple answer, and I'm sure Dr. Parikh will agree. Whenever there is such a big societal upheaval, it will increase anxiety at various different levels. Uncertainty anytime will breed anxiety, and I'm sure Dr. Parikh can talk about that. Not only is there uncertainty about the future of the country, about the future of the economy, about jobs, because there are now curfews in place at certain places. But that's, the underlying problems that come to the forefront because of that, due to racism, etc., and everything. They all foster insecurities, and I think it's a given that there will be some insecurities related to that. But I think that's a completely that's a 5-hour webinar on its own, separately.
No, I think Ankur, what you are saying is right. Beyond the individual examples, let's accept that anything which is sudden, unprecedented, comes with a sense of threat, brings an upheaval, brings collective arousal, brings any kind of violence or threat of violence, brings any kind of threat to individual or groups of well-being of groups. It is bound to give us existential anxiety. It's bound to give us anxiety about the future, about children. That is a given. I don't think this question or this discussion stops here because this is a given. The response that we need to have in civic society is how do you prevent this from rehappening or anything like this from rehappening anywhere in the world? When we don't recognize undercurrents, when we don't do basic preventive, socially corrective measures in a consistent manner, and do not ensure well being at a social level, every now and then the theme, the topic may well be different. So, that theme or the trigger is just a reflection of the underlying unrest at a societal level, which we just don't get the time to address. We are lost in marks, percentages, EBITDAs, and P&Ls.
Thank you, sir, for the answer.
Very well put, sir.
Sir, we have one question from Dr. Su. He wants to know that COVID is still a serious problem in the society, although the mortality rates have started coming down.
It is still a societal problem, yes, because of the sheer spread and the sheer speed with which it afflicts individuals. So as I said, even though the case fatality rate has gone down from the initial high of 10%, which is what people were believing at that time, down to probably closer to 1% or even less. The problem is 1% or even 0.1% of the population is a huge number, and it will completely overwhelm the medical system. Now, I am a second level provider behind Ankur. Ankur is critical care, so he's frontline. I'm one level behind him, but I also feel the effects of it on my neurology service because it overwhelms the system. You cannot manage your regular stroke patients, your regular epilepsy patients, your regular heart attack patients, because you're completely overwhelmed by the system. Second problem is COVID can also affect the healthcare providers who are taking care of these patients. It's an infectious disease. So if you eliminate your healthcare providers, you're again left with the same problem. Not enough providers, not enough healthcare facilities. So please take it seriously. Even if the case fatality rate goes down to 0.01%, multiplied by the population of India, and you will understand the burden of this disease. Not something to take lightly, but again, as providers, we do have available information. We have to act on that information, forget all the superfluous, the other rumors floating around. Those are not important to us. What is important is how do we manage this in a scientific way.
Thank you, sir.
And just
Thank
one
you.
more thing that I would add to that is we should not only focus on the fatality rate, because this is also a disease that causes a lot of morbidity in addition to mortality. And that obviously, from everything that Dr. Kedar said, we add on to the fact that there is a significant burden of morbidity. People are sick but may not die, and there's so this is definitely, and because it is a lot more infectious than some of the other things that we've seen come around before, more people will get it, and the total burden of disease that we will see it definitely makes it worthwhile taking the time to understand it and not be overly scared, but give it the proper degree of concern that we have to give it.
Yeah, respect COVID.
Yes.
There we go.
Correct, sir. Thank you, sir, for answering all the questions so patiently and so precisely. I have a message from Dr. Ashish Chawla. I think you know him, Dr. Ashish Chawla. He's saying good to see all of you.
Yes,
And
we know Ashish Chavla very well.
and he's
we know Ashish.
also congratulating Dr. Samir for a wonderful talk. And he's saying that you're always a great orator.
Yeah, that's all from school. That's all from school. That's all.
Okay. So, sir, on the behalf of Wockhardt, I would like to thank all of you for sharing your expertise, your thoughts on the impact of mental health by COVID-19. I'm sure our audience who are attending this webinar have gained and will apply in their clinical practice. And I would also like to thank all the audience, all the participants, doctors attending this webinar. I would like to thank you from the bottom of my heart, and thank you all.
Thank you.
Thank you.
Thank you.
There is a
Sachin
small,
and Samir, thank you so much.
there is a small poll. All the participants are requested to please give your poll on this online poll which is there. Thank you, Dr. Samir, Dr. Sachin, and Dr. Ankur, and Dr. Kapil.
Guys,
Thank
Right.
you.
Thank you guys for
Thank you.
organizing this.
Thank
Samir,
you, sir.
Sachin, it was great to see you guys.
great to see you.
Absolutely, Samir. Yes, Ankur and Nitin, Dr. Kapil, thank you so
Thank
much.
you. Thank you, sir. Thank you.
Take care. Bye bye.
Bye.
Bye.